My name is Luke Plaisir, and this is the wound final video for integumentary specialty practice. And this is case 6 for a neuropathic ulcer. So, looking at the wound, as far as etiology goes, likely causes of this wound, obviously, peripheral vascular disease, diabetic neuropathy, with his uncontrolled hyperglycemia. And we also would need to carefully evaluate to see if Charcot foot was present and a possible cause of what we're looking at as well. We would classify this as a stage 2 on the Wagner scale because it's a deep ulcer with no bony involvement or abscess as far as what I can tell from the pictures. We would need to grade out the stage of the wound, and we can't do that with a normal pressure ulcer scale, so that's why we need to use the Wagner scale. Because it is a diabetic case, so it's not just a typical normal pressure wound. As far as tests and measures go, I would want to do a monofilament test just to determine what the sensory integrity is, both on the affected foot as well as the unaffected foot, just to kind of get a baseline of where he's at and whether or not he's lost protective sensation or not. It may be obviously, fairly clear that he probably has, since he already has this wound, but just to make sure and kind of get a baseline to know what we're working with and what kind of patient education we need to be giving based off of what we find from a monofilament testing there. So again, do that bilaterally to see if they're both at the same stage. The description of the wound, obviously the case tells us pretty straightforwardly that it is 2.2 centimeters long by 5.7 centimeters and 3 centimeters in breadth with 2 centimeter tunnels at 12 and 6 o'clock positions. Obviously, this is on the plantar surface of the foot. Prior to debridement, the wound presents with slough and low to moderate exudate. And in correlation with the Wagner scaled stage 2 rating, we should expect this to be a full thickness wound, since those two go hand in hand. The tissue surrounding the wound is inflamed and dry, which we'll address later. I would elect to do Sharp's debridement of the slough in the wound. And following that debridement, based off of the pictures, it looks as if there's 50% viable tissue, 50% unviable infected tissue. And I would elect to do Sharp's debridement because I feel like it's most appropriate due to the fact that we can be meticulous and specific in our debridement. The wound appears to be deep and full thickness and possibly infected, and so we really want to get that slough out of there and be specific about it. And be careful, since it looks to be a deeper wound. So we don't want to just go blasting, with mechanical debridement sort of a thing. I would say that Dakin solution would be appropriate in this scenario, although I would not recommend or want to use an iodine-infused dressing or a topical antibiotic like a cream or something, since that could just add to the issues that we see. Although a saline-infused wound or like a gauze would I feel like would be fine for this patient. Which does bring me to the type of dressing that we would want to go with. Ultimately, obviously, we want to choose a dressing that's going to help to control the exudate and the odor, alleviate pain for the patient, and contain the wound infection, and kind of get rid of that infection and move towards nice, red, healthy, granulated tissue that we can get healing. Therefore, based off of all of that, I would want to try to use some alginate strips to pack into some of those tunnels, some of that deep cavity of this neuropathic ulcer, as alginates would help to absorb the exudate, provide hemostasis, allow for easy and atraumatic dressing changes as needed, and lend obviously any of those bacteriostatic benefits that we've talked about in class that come with those alginates. Of course, if we use an alginate, we have to consider that we would need an additional gauze or film on top of that alginate to help seal off the wound, to protect it, to provide that moist environment. And so I would use one of those gauze, like a non-adherent gauze, or just like a typical film dressing. I honestly would probably go with the film dressing because you can use those with infected wounds, no problem. The alginate, it works well with the alginate. So I would use a film dressing on top of the alginate that I pack inside the tunnel wound. I would also want to use a lotion to kind of help moisturize the surrounding tissue, because obviously, as we see in the video, it's dry and needs some TLC there in order to prevent future issues. As far as additional modalities or anything I would want to use, I thought that a total contact cast would be ideal, but if it is infected, then we don't want to use a total contact cast. So based off of that, I would use an ortho wedge screw to kind of help offload some of the pressure that led to this ulcer in the first place. And then obviously give patient education about offloading and how important that is. And I guess more patient education goals that I would want to focus on. We really want to get this patient's diet under control. Obviously, he's kind of not been the best about his attitude or his desire to get his diet under control. So I think really thorough patient education on diet, controlling that blood sugar level in order to avoid future ulcers, not only on the affected foot, but on the unaffected foot, help to protect those blood vessels. And so we avoid Charcot's foot. We avoid, that bone, that breakdown that leads to Charcot's foot. We promote better healing by keeping those blood vessels as healthy as possible, as well as kind of bringing down the hypertension and his hypercholesterolemia, as those are comorbidities that are barriers or potential barriers to him healing properly. Obviously, healing is a huge challenge with diabetic patients already, so just really giving him that education that diet is huge and will be a huge benefit if we can get that under control. So with that, I would want to challenge him to set a goal for something that is healthy for his blood sugar levels, something like having consistent post-meal blood glucose levels. Obviously, that means within 1 to 2 hours after eating, of less than 180 milligrams per deciliter. That's a little bit higher than what we want ideally, but I think that's a good starting point to try to get under control as soon as possible with some good patient education and a plan moving forward for how he can obtain that goal with meal planning or whatever else we need to do. As well as we'd obviously want to use some patient education about daily foot checks to make sure that he doesn't have any callousing or inflammation or points of repetitive rubbing that may lead to another foot ulcer, as well as footwear to evaluate his footwear, see if that's healthy, if it's good, if it's leading to some of these problems, and then maybe even giving him a rocker bottom shoe for the unaffected foot to use. Obviously, you don't want him walking around a ton with his affected foot the way it is, but just having that conversation about footwear and the importance of having good footwear in the future. And then, so obviously another goal we could set is having daily foot checks and getting on a regular schedule, and so those are consistent, and so he has that in his scheduled daily plan every single day to prevent future problems, and so we don't run into another foot ulcer down the road. So all in all, that's my summary for this wound, or this neuropathic wound, and my submission for the final video.